Hi, good afternoon to those on the East Coast, and good morning or good evening to those joining us from other time zones. Thank you all for being here today. My name's Abby Zhang. I'm the president of the HES Psychology Student Club. I'm joined by our amazing club leaders today, including Annie Farrell, Maya Bach, Scully Wang, and Katrina Longhurst. Today's session will begin with Dr. Pace-Schott's presentation, followed by a Q&A. Please feel free to share your question in the chat throughout the event or ask them live during the Q&A session. Now, it's my great pleasure to introduce our guest speaker, Dr. Edward Pace-Schott. Dr. Pace-Schott is Associate Professor of Psychiatry at Harvard Medical School and Massachusetts General Hospital and Director of the Sleep and Anxiety Disorder Laboratory. He received his PhD in behavioral neuroscience from Boston University, and his research focuses on how sleep helps regulate human emotion and how this process is altered in psychopathology. Using methods such as polysomnography, neuroimaging, and psychophysiology. His work examines how sleep interacts with anxiety and trauma-related disorders, including post-traumatic stress disorder. He is especially interested in learning and memory processes such as fear extinction and habituation, key mechanisms, emotion regulation, and treatment such as exposure therapy. His research also explores how sleep-based intervention may support the treatment of anxiety disorders. We're very delighted to have him with us today to share his insights on sleep, emotion regulation, and mental health. Dr. Pace-Schott, the floor is yours. Thank you so much for
Okay,
being here with us.
good. Well, thank you so much for having me and for the nice introduction. And I'm going to give you a talk, and it's going to be, um, we'll see how long it goes. I'm not assuming that you guys know about sleep physiology. So I'm first going to review sleep. Um, and then I'm going to talk about emotion regulation and sleep and and then about psychopathology and sleep. And then finally, I'm going to give you some examples of the work that we're doing in my laboratory, if we have time. So let me share. Starting. Okay, continue. Share. Okay, let's see. I can also get rid of this thing. Oops. No, I guess I can't. Okay, well, good. So we had an introduction, and so I'm going to first start out by saying that sleep is composed of a number of different stages, and these stages alternate in the adult human at about 90 to 120 minutes. And the stages include awakening or awake, stage one, um, what we call non-REM sleep, which is basically everything other than REM sleep, stage two and stage three. This is deepening stage non-REM sleep. And then finally, there's REM sleep, which is a state that is very close to waking in terms of the way our brain is activated. So given that there are 90 to 120 minutes of them, you have as many of these cycles as you can have during the total amount of time you sleep. And the earliest part of sleep is when, at least in young adults, is when you get the deepest stages of non-REM sleep. It's sometimes called slow wave sleep, and in a moment you'll see why. And so early in the night, you have more slow wave sleep. But as the night progresses, and especially toward the end of the night, you have more REM sleep. And that's one of the reasons why if you sleep in the morning, oftentimes you'll remember more of your dreams. REM is a state that is the most favorable for dreaming. But it's not the only state that dreaming occurs, but it's the one that's most favorable to dreaming. And the way sleep is measured is by a method called polysomnography, which is simply three biosignals. The electroencephalogram, which measures brain waves, measures voltage changes, voltage oscillations occurring that you can measure at the skull or at scalp. However, these are what are going on a little bit below that in the cortex of the brain. And EOG is the electrooculogram, and that records eye movements, horizontal eye movements. And that's very important for staging sleep, particularly REM sleep. REM stands for rapid eye movement sleep. So that's one of the ways you detect it. And then the EMG is the electromyogram, and that records the muscle tone in your skeletal muscles. And during REM sleep, it has some peculiar features. So there are three main behavioral states that I've mentioned, being awake, being in non-REM sleep, and being in REM sleep. And they each have a very distinct signature in the PSG. And even without getting into what these different channels are, you can just see how different they look if you look at the EMG, EEG, and the EOG. So I had mentioned that sleep gets deeper through these four stages. And what do I mean by deeper? Well, deeper usually refers to the depth, usually refers to the EEG, the electroencephalogram signal, which again is the oscillation of voltage that's measured at the scalp. And deeper sleep shows slower frequency. Frequency is expressed in cycles per second or hertz. So as it gets deeper, the frequency, the way it alternates up and down, slows, but the amplitude increases. And so just to illustrate, here is wakefulness. In wakefulness, we have very low amplitude but high frequency oscillations in 13 to 80 hertz. And so you can see that that's very fast, 80 cycles per second. Then just by closing your eyes, you start to generate another rhythm called alpha rhythm, which is slower than that, around 8 to 13 cycles per second, and it's very regular. So that's being awake, but with your eyes closed. And then as you start to get into non-REM sleep, you have a slowing frequency in growing or enlarging amplitude, and um, some of the wave forms are sometimes called theta. That's 4 to 7 hertz. And then finally, when you get into slow wave sleep, stage three non-REM, you have these large amplitude delta waves at 1 to 4 hertz. And there's also a very slow oscillation that takes place at less than 1 hertz, which we won't talk a lot about, but is very important for learning and memory, which consolidate during sleep. And the reason is thought that the amplitude increases is because during the deepest stage of non-REM sleep, a lot of the neurons in your cortex are doing the same thing at the same time. So their amplitude adds to one another, their voltage adds to one another. Whereas in the more activated states, every time there's a voltage in one direction, some other part of the brain is having a voltage in the opposite direction. And they sort of cancel each other out, but they happen very quickly. So let's just take a little closer look at each of these stages. So this is what wake looks like. Again, 13 to 80 hertz. It's even faster in rodents. Um, and with your eyes closed, you start to generate this alpha rhythm. Now, stage one non-REM is the transition between wake and sleep. A lot of people, if you call their name when they're in stage one, ask if they're awake, they might say yes. But it is a transitional state. It's sort of the state you get into when you're sitting in a boring lecture, for example, and you suddenly are in another world. That's your transition from wakefulness into stage one non-REM. And the oscillation that replaces the alpha rhythm is this theta rhythm. And one of the um, features of stage one non-REM are these slow rolling eye movements. And you'll see in a moment why this is slow. It's movement from side to side. Good, I can get rid of this thing. And that's recorded as the two eyes, the signal from the two eyes either diverging or converging. Then you get into a slightly deeper stage of non-REM, stage two. And there, the EEG remains at this theta rhythm around 4 to 7 hertz, but you have some distinct waveforms, which are very intensively studied these days because they're thought to be also like the slow oscillation involved in memory consolidation. And one is called the sleep spindle. It's called a spindle because it's shaped like a sewing spindle. It sort of starts small, gets big, and then gets small again. And you have a number of them every second, I mean, every minute. And then K complex, which is sort of like the next stage. It's sort of like presaging the next stage. And then during slow wave sleep, you can see that the amplitude has grown, the frequency has slowed to 1 to 4 hertz, and superimposed on this is something called the slow oscillation, which is even slower than 1 hertz. So it would take more than 1 second for one of these cycles from peak to peak or trough to trough to finish up. And this is, again, what is thought to be very important for learning and memory. And we won't get into that tonight just because or today, because there's too much to it. But again, the um, the reason it's thought that you have this high amplitude is because lots of neurons are doing the same thing at the same time. So it's sometimes called synchronized sleep. And the EEG and the EMG also change. One thing to notice about the EOG is that if the two eyes are doing the same thing at the same time, rather than diverging and converging and diverging, that indicates that this is artifact coming in from the other channel. So it's a very good way to differentiate this true eye movement from some other signal that's getting into that channel. And all this time, the EMG has been going down. However, then you get into REM sleep. And as I mentioned, REM sleep is very similar to waking. The EEG here is high frequency, low amplitude. It takes experienced polysomnographer to be able to differentiate that from wakefulness. And it has these rapid eye movements. Now, you can see that they diverge and converge much more quickly. And that is in contrast to those slow eye movements we saw in stage one non-REM. And one of the peculiar features of REM sleep also is that you have very low muscle tone. And that's because your brainstem is, in fact, it's paralyzing your skeletal muscles. It's sending signals down your spinal cord to the motor neurons going to your muscles and telling them not to fire. And so even though you look like you're awake, if you look at the EEG, and if you oftentimes if you ask somebody, wake them up and ask them what's going on, a lot will be going on in terms of dreams. However, their EMG looks like they're as quiet as you can be. So that's why REM sleep is sometimes called paradoxical sleep or active sleep. It's paradoxical because the EEG looks like you're awake, but the EMG looks like you are sound asleep. Now, there are two processes which are important to know about just in learning about sleep that is thought to control our propensity to sleep or be awake at different times of the day. And these include something called process S, or the sleep homeostat. And this is simply a drive toward sleep, which increases the longer that you are awake. And so this is the upper line here. And if you were, for example, to sleep deprive someone, it would just keep going up and up and up and up because the longer you're awake, the more it drives you towards sleep. The other process is called process C, and this is your circadian rhythm. And you have a circadian rhythm of the drive toward wakefulness. And the combination of these two produce a consolidated night of sleep or a consolidated bout of sleep. So the way they do that is that when this homeostatic drive to sleep is at its maximum, after you've been awake all day, the drive toward wakefulness from process C, from the circadian clock, also is at a maximum. And this is sometimes called the wake maintenance zone. Most of us experience that sort of as a second wind after dinner. And then at the other end of the thing, of the cycle, in the morning, after we have, in a sense, slept off our sleep pressure from the homeostat and would ordinarily wake up, this is when our circadian drive towards sleep is at, I'm sorry, toward waking is at its lowest. And so we remain asleep for a little bit longer. And this is sometimes called the circadian nadir. This is when your body temperature is minimal and has some other features as well. Now, human circadian rhythms are include the sleep-wake rhythm, but they also include many of the other physiological rhythms. And these things tend to occur in a certain relationship to one another. And so in this case, this is an individual who at 9 o'clock, the melatonin starts to go up in his bloodstream. Now, when melatonin starts to go up in your bloodstream, actually it's measured in your saliva, that is a very good indicator of how your circadian clock is aligned with the clock on your wall. But this individual um, could also have melatonin secretion start at 10 p.m. And you can see that all these other events also shift toward what's called an advance. I'm sorry, a delay. The melatonin secretion is delayed, or it can get earlier. In this case, there is a increase in melatonin, which usually happens about an hour and a half to 2 hours before your normal time of going to sleep. And here it occurs around 7 p.m. So you can see that this is an advance, this is a delay, and we're going to talk about delayed sleep phase as being one of the symptoms of a lot of psychiatric disorders. So if we talk about psychiatric symptoms, this is just a quote from a article, and it's saying that sleep problems and psychiatric problems co-occur in almost every psychiatric disorder, and that includes both the mood disorders, the psychotic disorders, the neurodegenerative diseases, the neurodevelopmental diseases of early life. So sleep is very intimately included in what is helping us to develop and to learn to regulate our emotions, as well as learning to many, many other things. In very early life, sleep is essential for making the connections that mature our brain, both in utero and in the first years of life. Now, one of the evidences that poor sleep and is related to pathology, or at least to poor mood states, um, is that in healthy individuals, you can measure both the sleep disturbance with a measure called the PSQI. That's the Pittsburgh Sleep Quality Index, which is the most commonly self-report measure of sleep quality. And as it goes up, your sleep is getting poorer. And these two measures are sort of a personality measure and a state measure of neuroticism and anxiety. So you can see even in very healthy males, these were all um, young men, students, many were athletes at University of Massachusetts, and you can see that even across the normal range of these different levels of anxiety and sleep, as you become more anxious, your sleep is poorer, or as your sleep is poorer, you become more anxious. And this also occurs in the circadian rhythm, in that morningness is associated with, in other words, people who are morning types or larks, they have less neuroticism and less anxiety. This number increases, you're more of a morning person, and as it decreases, you're more of an evening person. And you can see that here, when you're very much of a morning person, you have very low levels of neuroticism and anxiety. However, if you have low morningness and high eveningness, you have a greater propensity to develop psychiatric disorders, um, neuroticism and anxiety being just a measure across the normal range. Um, Now, again, these individuals are all healthy psychiatrically, and this range of values is normal. But you can see that the tendency for more eveningness to be associated with more propensity to be anxious or to develop psychiatric disorders. So sleep promotes our emotional regulation, our emotional homeostasis is one way to refer to it. This is our emotional equilibrium. Um, and some of the ways it promotes that is that sleep will support those circadian oscillations. Now, the circadian rhythm is independent of sleep, whether you're awake or sleep, but sleep supports that oscillation. And that oscillation is actually 24 hours, almost precisely 24 hours throughout your lifespan. Sleep also regulates our hormones. In some cases, it is it actually is responsible for the secretion of hormones like growth hormone or hormones that are controlled by the circadian clock. It also modulates those, and one of the hormones that's associated with the circadian clock, controlled by the circadian clock, is cortisol, as well as melatonin, which we just mentioned. Um, Sleep is thought to restore or rebalance our interoceptive perception. Now, interoceptive means our perception of what's going on in our bodies, our perception of how we feel. And um, there are parts of your brain that are dedicated to interoception, just the way the parts of your brain are dedicated to vision, hearing, and touch. There is a part of your brain which is associated or processes interoceptive signals. And those can, if they're imbalanced or abnormal, you'll feel lousy. And if they're balanced, you will feel better. And you may not know exactly what's contributing to that, but the interoceptive signaling to your brain is responsible for a lot of that. Now, there's something called the autonomic nervous system, which probably a lot of you who have taken psychology or biology, neuroscience have been exposed to, but these are the automatic, involuntary signals from our brain which control our viscera and our muscles automatically to achieve different things at different times. So the parasympathetic branch of the autonomic nervous system is sometimes called the rest and digest branch. That means that it promotes restfulness, it promotes digestion, it promotes relaxation, sleep. Whereas the sympathetic branch is sometimes called the fight or flight response. And this, for example, directs your blood to your muscles for fleeing or fighting and directs blood away from your viscera to be used in the activation of our muscles. And it's turning out that something that is a very strong influence on mental health is inflammation. And we all know inflammation when we get, for example, an infection or we get damage, break a bone or something like that. It inflames the uh, the tissue swells, it hurts, etc. But what's going on, what's controlling that are some substances that are secreted into our bloodstream by various organs. And um, those substances are either pro-inflammatory or anti-inflammatory. The pro-inflammatory ones, if they're present for a long period of time, they can actually start to damage your organs. And so sleep is an anti-inflammatory state, and every night it sort of turns down that inflammation. Also, there's some interesting things that have been more recently discovered. For one thing, it sort of cleans up the brain. It does a lot of housekeeping in the brain. And one thing it does is it sort of gets rid of the the records of irrelevant experience. Every time you have an experience, in a sense, it's being encoded in your brain in some way. And most of that is irrelevant. And so sleep is very important in sort of sorting the importance connections from the unimportant connections. And it also clears, particularly that deep, slow wave sleep, it clears metabolites from your brain, in particular, proteins that have misfolded. And that's usually what is behind all of the dementias and neurodegenerative diseases. And this is sort of a flushing of the brain. It's bulk transport of cerebrospinal fluid from areas around our arteries to areas around our veins. And it is something that has been recently discovered and is thought to be clearing the brain of some of its waste. And that's called the glymphatic system, which is a combination of two words, glia, which are these nutritive cells in the brain, and lymphatic, because it sort of acts like the lymph system. But one thing that we're mostly going to talk about, because it relates directly to emotion regulation, is the interaction of sleep with memory and neuroplasticity. Now, neuroplasticity refers to the fact that, again, every experience you have changes your brain in some way if you are to recall it. So even very simple things like becoming habituated to a loud sound, repetitive loud sound, you live in a noisy spot. Um, Even that is a change in your brain and can be considered a form of memory. Um, and there are a number of memory systems. We don't have time to go into it, but all of them have a relationship to sleep. And one stage of sleep that we talked a little bit about is REM sleep. And this is thought to be very important for emotional memory and for emotion regulation. Now, the reason it's thought to be that way is, first of all, because during REM, some of the neurochemicals in our brain that are most active when we're awake and which actually do wake us up, they reach a minimum. So that's another paradoxical thing about REM sleep, is that even though your muscles are paralyzed, your brain is at its lowest level of the wake promoting substances. Um, most of the mood and anxiety disorders, we'll talk about that a little bit tonight, have abnormalities in REM. Um, Stress in both REM, I mean, in both rodents and in humans, experimental animals and in humans, affects REM. In some cases, it will reduce the amount of REM a rodent will have. It will break up the REM periods in humans. Um, we all know that dreams are associated with our emotional state. And in psychotherapy, some psychotherapists work a lot with dreams to try to affect the emotional health of their patient. And many behavioral and neuroimaging studies suggest that REM sleep um, affects our emotional state, that it reduces arousal or it moderates arousal. Now, all that being said, there are also experiments that show that REM actually preserves some of our memories, and in particular our negative memories, and it also increases our emotional reactivity. So if you don't have REM, you might actually be less emotionally reactive. So this is just something to keep in the back of your mind when we talk about the different psychiatric disorders. So I mentioned that sleep is involved in learning and memory. And when you learn something, when you encode something, you create a change in your brain. And when you retrieve that information, like you learn for a test and then you retrieve it when you take the test, um, that is two steps that occur when you're awake. However, what sleep is most important for is an intermediate step called consolidation and integration. Consolidation is simply the fact that unless you strengthen a memory by a biochemical process within the cells, you might lose it. Memories or connections that are not consolidated are generally forgotten. Integration means simply that you are putting memories where they belong in your store of memories. You're not sort of piling up memories like index cards in your brain. You're sticking your new experiences where they're most relevant. And this is the case for declarative memory, which are events and facts, procedural memory, which are skills and habits. These are what have been studied the most. However, emotional memory is also something that is consolidated and integrated during sleep. And emotional memory can be things that are associated with actual autobiographical events, which sort of combines emotional memory and what's called declarative memory, autobiographical memory, but it also includes some low-level type of memories that we share with most of the animal kingdom. And these could be non-associative. In other words, they don't associate one thing with another, like becoming sensitized to something that we repeatedly experience, or to habituate to things that we continually experience. And then there are associative memories, and there are two steps to this. One is conditioning, which is associating something that is neutral, that has no particular emotional meaning, with something that is inherently pleasant or unpleasant. And if you associate those two things repeatedly, soon the thing that was initially neutral will evoke the same response as the thing that was either highly pleasant or highly unpleasant. This is how Pavlov's dogs were trained by the ringing of the bell to salivate. It's also what we think occurs in post-traumatic stress disorder when people develop all of these triggers that trigger the memory because they're associated with their memory of the trauma. And then finally, there's fear extinction. And fear extinction is very interesting. It's a new memory, and we'll talk about that in a moment. But it is learning that something that you once feared, you no longer need to fear. Okay, so we're going to talk mostly about negative associations because we're talking about psychopathology. So there are a couple very important theories about sleep and emotional regulation and memory. And the one that probably some of you are familiar with from reading Matt Walker's book, Why We Sleep, is the sleep to remember, sleep to forget theory. And this asserts that as you have successive nights of sleep after having had an experience that is emotionally charged, either positively or negatively, um, as the nights progress, you slowly get rid of the emotional envelope or the emotional charge of that memory, but you retain the memory. In fact, the memory can get strengthened by the consolidation process. And so this pertains to declarative memories, autobiographical memories, but there are also um, these systems which support um, the associative learning, such as fear conditioning. These are what happens when somebody is exposed to a traumatic event. These things will be strengthened. And there are also are networks that are involved in teaching somebody that what they once feared, they no longer need to fear, called the extinction network. So what is fear conditioning? I'll give you just an example. Say we have an experiment where there's a neutral stimulus. In this case, it is just a blue square, and we associate that blue square with a mild electric shock. We actually do this. People choose their own level of shock. It's not terrible, and we can study fear conditioning and extinction in this way. So when you associate a something with a shock, after a while, that thing that was initially neutral, becomes able to evoke the same kind of response as the shock itself. This is skin conductance response, which is a good indicator of sympathetic nervous system activation. And eventually, the thing that was initially neutral will evoke that response. Then, when you extinguish that fear, what you do is you present the thing that evokes the conditioned response over and over and over again. The conditioned response diminishes, and you would think that what's happening here is that you're erasing the fear. That's not actually what's happening. Extinction is a new memory, and it doesn't erase the original fear memory. It creates a new inhibitory memory that simply says what you once feared, you no longer need to fear. And so extinction memory is the basis of a lot of psychotherapy. It's the basis of, for example, exposure therapy for spider phobia or social phobia, etc. And so it's a very important process. And in anxiety disorders, which is what I study, you can think of that as excessive fear conditioning or excessive or impaired extinction learning. But what it turns out is most often the case, it's impaired extinction memory. So somebody learns to fear something, then they can learn to not fear it, but they forget that, and the fear comes back. Actually, for good evolutionary reasons, our fear is much stronger than our extinction. So we don't, incorrectly assume that nothing bad is going to happen just because nothing bad happened once. And these low-level processes also are involved in the perpetuation of some of these um, dis symptoms of disorders. One thing in particular, it's involved in the generalization of fear. People who have PTSD initially fear things that remind them of the trauma, but after a while they start to fear things that remind them of the things that remind them of the trauma, and become very fearful of a lot of different things and restrict their lives. And then finally, as I mentioned, extinction and also habituation are very important elements of exposure therapy. And they are actually used in a lot of the disorders I'm going to describe in a moment. Now, sleep, one of the strongest pieces of evidence that sleep is involved in psychopathology is the fact that anxiety disorders and depression as well are very closely related with sleep, poor sleep, and insomnia in particular. And so if you have an anxiety disorder or a mood disorder, it's very likely that you're going to have some degree of insomnia. But what has been recently discovered is that insomnia also increases the odds of you developing a mood or anxiety disorder. So, in other words, it's not just another symptom of poor sleep, is not just another symptom of these disorders, but it's actually something that may contribute to these disorders arising in the first place. And one of the reasons we think this might be the case is that um, poor sleep may disrupt some of these emotion regulatory circuits that control things like extinction memory, and poor sleep will then increase the probability that one will develop symptoms of an anxiety or a mood disorder. So I'll just go through, I guess, very quickly some of the different psychiatric disorders and what is changed in them with regard to sleep. So some disorders, sleep problems are actually part of the diagnostic criteria. And for PTSD, it is. Nightmares and sleep disruption are core symptoms of PTSD. And when one studies the sleep of people with PTSD, you can see that there's things like an increase in the very light stages of sleep, a decrease in the very slow wave sleep, um, changes in REM sleep. And this is all consistent with the notion that there's an underlying hyperarousal that takes place when somebody develops this disorder. And there have been studies that have shown that people who have poor sleep or short sleep prior to being traumatized are much more likely to develop PTSD. And this has been shown quite a bit in the deployment of soldiers in the recent conflicts. Soldiers who have sleep problems before being deployed are much more likely to come back with PTSD if they have a traumatic experience. Similarly, people who have nightmares before they're deployed, and this also occurs in civilians. These are people who have had motor vehicle accidents that were interviewed in the emergency room, and the ones who have reported that they habitually sleep poorly, are much more likely to develop PTSD. And the effect of a trauma on sleep predicts whether or not one is going to develop PTSD. So PTSD involves things, again, like nightmares, insomnia, avoiding sleep, thrashing around during sleep, panic attacks, etc. And these symptoms are particularly resistant to treating PTSD. Now, PTSD is treated with things like exposure therapy and cognitive processing therapy, and those are very effective evidence-based treatments that help the daytime, the waking symptoms of PTSD. But the sleep symptoms, like insomnia and nightmares, seem to persist and are to be insensitive to a lot of the treatments that fix the daytime symptoms. However, if you target sleep in these individuals, if you give them, for example, cognitive behavioral therapy for insomnia or CBTI, it also improves their daytime symptoms. And if you treat comorbid sleep disorders, for example, SDB is short for sleep disordered breathing or sleep apnea, you actually can treat people more effectively. Now, another anxiety disorder, generalized anxiety disorder, I'm assuming a lot of you have had sort of a general psychopathology or abnormal psychology course, but generalized anxiety disorder is people who are like chronic worrywarts. They worry about everything. And if they stop worrying about one thing, they start worrying about another thing. And this is the disorder that is most often coexisting with insomnia. It's a diagnostic criteria for insomnia is one of the diagnostic criteria for this disorder. Um, all of the indices of sleep quality, such as how long it takes you to go to sleep, how often or how long are you awake during the night, and also how much of the deepest stage of sleep. All of those things are changed in the poorer direction in people who have generalized anxiety disorder. And again, this is thought to reflect the fact that our brain's circuitry for controlling negative emotion has been is disrupted by poor sleep and allows this disorder to arise, allows pathological worrying to arise. Now, many of the other anxiety disorders, even if you don't see um, characteristic um, changes in sleep, they are associated with poor sleep. So, social anxiety disorder, people, this is people who are really avoidant and frightened of social interactions. Um, it goes along with poor sleep. It goes along with insomnia. And if sleep improves while somebody is being treated, they will have more success in that treatment. Panic disorder is another disorder where sleep problems are very common. Most people with panic disorder report sleep problems. It interferes with all of the sleep quality measures. Sleep latency is how long it takes you to go to sleep. Um, it's also associated with some sleep disorders. Sleep paralysis, which we may talk about, is a disorder where you wake up and you're unable to move, and panic disorder is associated with that. And panic attacks can arise from sleep just as often as they can arise from wakefulness in somebody who has panic disorder. And even obsessive compulsive disorder had it was initially thought to people with OCD would sleep just the same way as normal individuals because they couldn't see very distinctive changes in the sleep in the polysomnography of them. But as it turns out, um, they have delayed sleep phase problems. And the more their sleep is delayed, the poorer is their response to exposure therapy, exposure and ritual prevention, which is the standard therapy for OCD. And so this is possibly a circadian disorder that goes along with OCD. And it, 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 like many other disorders, the sleep problems and the daytime symptoms exacerbate each other. So it turns into one of these vicious cycles where more symptoms gives you poorer sleep and poorer sleep gives you more symptoms. Now, in depression, this is one of the disorders that has been studied quite a bit in relation to sleep, and it is involved often with sleep disruption. But the particular thing about depression is that it seems to disinhibit REM. REM seems to be intensified by depression. And so it takes shorter to get into REM sleep. And the first period of REM, which is normally quite short, is extended. REM density, which is the eye movements that you are experiencing during REM, is increased. And most antidepressants, in fact, the traditional ones like SSRIs or tricyclics or MAOIs, they all suppress REM sleep. And so there's a clear relationship of REM sleep with depression. And again, the deeper stages of sleep are suppressed. Um, and the sleep problems, like with PTSD, they often persist past the remission of daytime symptoms. And they also may be present in the first degree relatives of people with first degree relatives of people with depression. So they may be what's called an endophenotype, which is a sort of a trait or a genetic predisposition to developing a disorder. And these are sleep related endophenotypes. Bipolar disorder, as you might imagine, disrupts sleep quite a bit, especially during the manic periods. There's a real decrease in sleep and oftentimes insomnia. And sleep can actually trigger mania, the manic periods. And in depressive episodes, there is often insomnia or something called hypersomnia, which is sleeping too much. And even in between the different manic periods or different depressive periods, sleep still is something that stays abnormal. In psychotic disorders, in particular schizophrenia, there again are a lot of non-specific things associated with um, sleep, such as insomnia and reduced sleep quality. But in this case, there is a specific abnormality that's been found, and that is that you have fewer sleep spindles. And this is seen even before people are treated for schizophrenia. And it's also something that's seen in first degree relatives of people with schizophrenia. And so this is also something that's thought to be this endophenotype, this propensity that exists in one's first degree relatives as well as the patient. ADHD is again, sleep problems are very common, but ADHD, a lot of the sleep disorders actually can mimic ADHD when the person is awake. In particular, delayed sleep phase, where people are not getting enough sleep, they're going to bed very late. Sleep apnea actually also results oftentimes in inattention and can look very much like ADHD. And when it's treated, then some of the ADHD symptoms resolve. And there are a few actual differences that have been seen between people with ADHD and normal individuals or individuals without ADHD. But another thing about ADHD is that the psychostimulants which are used to treat it also are disruptive of sleep, particularly if they're not taken at the right time of day. Autism, the whole spectrum of autism has lots of different sleep problems associated with things like sleepwalking. Parasomnias are things like sleepwalking, um, nightmares, night terrors, sleep eating. um, and there are abnormalities in the circadian rhythm. And this is something that has been recently discovered, is that people with on the autism spectrum, at least some of them, have very low melatonin production. And they can be treated with melatonin and have some degree of improvement. And then finally, the dementias. All of the dementias have this feature, or most of the dementias, I'm sorry, have this feature of an accumulation of an abnormal protein, a protein that is synthesized but then folds abnormally and builds up in the brain. So in the case of Alzheimer's disease, it's the amyloid plaques and the neurofibrillary tangles of a protein called tau. And there's another one in disorders like Lewy body dementia or Parkinson's. And again, this is thought to at least in part be due to poor clearance of these proteins by this lymphatic system, by this sort of flushing of the brain. You can see here this movement across the brain from areas around the artery to areas around the vein and then out. And with aging, it could be that this is progressively disrupted, and it could be even more disrupted when somebody develops a neurodegenerative disorder. So this is a place we could stop and have some questions. And then if folks are interested, I can show you some of the things that we do in my lab.
Thank you. Thank you so much, Dr. Pace-Schott. That was really insightful presentation. Of course, a lot of information for us to absorb.
Yes,
So
yes.
yes, it's great. Thank you so much. We do have some questions in the chat. I
Sure.
think a couple questions are more related to the relationship between sleep and psychiatric disorders. It's more like that like any causal relationship because like for example, one participant asked curious that does going to bed very late, like around 3 a.m., increase the risk of psychiatry issues, or is it about overall sleep quality and consistency? Another very related question is that I'm now wondering if postpartum depression is further likely because of like a poor sleep. So what's your insight on like the relationship between sleep and the psychiatric disorders? Is there any causal relationships? Thanks.
The causal relationships are hard to clearly demonstrate, but in the case of, for example, postpartum depression, mothers who have sleep problems in the third trimester do have a statistically greater incidence of postpartum depression or postpartum PTSD. And in the case of delayed sleep phase, that's thought to be to coexist with pathological mood or anxiety. However, the causal relationship there is a little bit fuzzier. You know, it can clearly go both ways because people who are complete night owls who actually have the disorder of delayed sleep phase, whose melatonin doesn't go up in their blood until maybe 12 or 1 at night. Um, they have weird lifestyles and oftentimes have experiences during their normal um, normal life that could lead to depressive feelings. You know, they're isolated, for example. Um, but so that's a little bit unclear. But there's lots of genetic studies that link things like delayed sleep phase with other things like, for example, bipolar disorder, and some indication of a link with ADHD.
Great, thank you. Another question, in which sleep phase does somnambulism occur,
Ah,
and what happens neurologically during that active state compared with the rest sleeping one?
mhm. Well, sleepwalking is a parasomnia, and parasomnias in general are things that should happen all together during sleep, like your motor system and your consciousness, and your talking, etc., should all be suppressed during sleep. But what happens in parasomnias is that one thing that is should be associated with the other parts of sleep then activates and intrudes into sleep and creates a wake-like behavior. And in the case of sleepwalking, it's walking, but also there are disorders like sleep talking or sleep eating, or in some cases, if the emotional circuitry of the brain turns on very strongly during non-REM sleep, you can have what's called a night terror. And this is very common in young people whose nervous system has not fully matured. And so this is sort of the turning on of the autonomic nervous system without there being consciousness. Um, Now, the stage of sleep that this occurs in usually is non-REM sleep, and there are um, non-REM sleep associated parasomnias like sleepwalking, sleep talking, sleep eating, which is a very strange disorder, and some other even stranger ones. And there are REM associated parasomnias, and that includes this thing of sleep paralysis. Sleep paralysis is when you wake up, but that feature of REM sleep, which is the paralysis of your skeletal muscles, um, persists. So you wake up and you can't move your muscles for a few minutes. It can be quite frightening. Nightmares are considered a REM parasomnia, and there's also a REM parasomnia called REM behavior disorder, which has gotten a lot of interest because it turns out that it may actually be a very early sign of some of the dementias, some of the neurodegenerative diseases. And REM behavior disorder, when it occurs sort of spontaneously in an older person, may be the first sign of one of these disorders. And with REM behavior disorder, that atonia, that paralysis of the muscles, is not present, and so people actually act out their dreams. So the movement is unlike sleepwalking, where there's sort of nobody upstairs. In this case, they are acting out what they're experiencing in their dream, and sometimes can hurt themselves or hurt their bed partner. And it used to be thought to be just sort of a strange phenomenon that sometimes occurred in older folks. But when they followed these folks for like 8 to 10 years, they found that a very high percentage of them went on to develop Parkinson's disease, Lewy body dementia, or some of the other diseases that are caused by that particular protein.
Great. And a couple questions related to sleep medications. So, how sleep medications for insomnia interfere with sleep? And if these medications are helpful in treating psychopathology, or if these medications disrupt the cleansing of the brain that is meant to occur during sleep.
That's a very
So,
good
what's your
question.
insight on sleep medication?
Medications, that it is sometimes a trade-off, particularly with medications that are psychostimulants for ADHD, things like Adderall or Ritalin, because those can clearly disrupt sleep. Now, the antidepressants, most of them, your sleep, your slow wave sleep, and your REM sleep comes back to some extent after you get adjusted to the medication. So it when it exerts its antidepressant effect, it at the same time will you'll become used to it, so to speak. What is most problematic with insomnia are sleeping pills, or things like um, uh, Ambien or Lunesta. Um, these things are sort of second choice in terms of treating insomnia. The first line of treatment for insomnia is something called cognitive behavioral therapy for insomnia, where people actually learn not to or learn new habits and not to carry out old habits that contributed to their insomnia. And so with a sleep medication, again, like a sedative, a benzodiazepine, or even alcohol behaves in the same way. People will be put to sleep by the drug, but they ultimately become dependent on the drug. And when they stop using it, sometimes the insomnia comes back even worse than before. But in the case of antidepressants, not all of them disrupt REM sleep, but most of them do. And what is thought to be the reason why people don't, are not harmed by that in some other way is that your body, your brain adjusts to that, and you start to have a return of REM sleep and slow wave sleep.
Thank you. One last question, which is more related to everyone, I believe. So, in your view, what are the most significant gaps in current research on the relationship between sleep disturbances and emotion regulation in psychopathology? Are there specific area you think warrant future exploration?
Mhm. The actual link between poor sleep and the development of anxiety, mood disorders, psychotic disorders, and particularly neurodegenerative disorders, dementia. All of those things require a lot more research before we really know about that pathway from sleep to psychopathology. We know a lot about the other direction, about what kind of sleep problems people who have psychiatric disorders typically have. However, what we don't know is how exactly, the mechanism by which sleep problems increase the the likelihood may actually be part of the causal effect, not solely so, but part of the causal effects that end up with people having psychiatric disorders. And the one that's of most interest to people right now is is the glymphatic system and the slow wave sleep and the development of dementia.
Thank you. Thank you all for the great questions. And with that, we come to the end of today's session. I'd like to extend a sincere thank you to Dr. Pace-Schott for sharing his insights with us. Let's give him a big round of applause. Thank you so much, Dr. Schott. Thank you. If you're interested in learning more about the topic discussed today, Dr. Pace-Schott actually teaches a course at Extension School called Sleep and Mental Health. So I think we highly encourage you to explore it further and consider joining the class if you have the chance. And thank you as well to everyone who joined us today. We hope to see you in the future event and have a wonderful rest of the day. Thank you so much again, Dr. Pace-Schott. Thank you.
Good, and I'm happy to correspond with anybody. You can find my email on the Extension School website, and shoot me an email if you have questions about sleep.
Thank you, everyone.
Thank
Bye.
you so much, Professor Shaw.
Cheers.
Thank
Good
you,
night.
everyone.
Goodbye.